Our next speaker is Dr. Ismaili. She'll be talking about diagnosis and management of lymphoproliferative lesions. There's something fishy here.
Sure. Thank you. Okay. Thank you so much for inviting me to this cornea subspecialty day, the second year that I'm enjoying the topics very much. So I have no financial disclosures. I think I'll start by just showing you some photos of conjunctival. I focused on conjunctival fishy lesions, just in the way of diagnosis. This obviously is a very typical case of salmon patch infiltrate, a case of multiple lymphoma. But I'm going to just show you various different photos just to commit to memory various different manifestations of the same process. This one being in the upper tarsal plate. Eversion of the upper eyelid is really important for finding the full extent of conjunctival lymphomas. Just various different, really the entire ocular surface needs to be inspected. Sometimes you could have a lesion that's quite small, just limited to the caruncle, or just a small follicular infiltrate. In all of these cases, of course, the patient could have some symptoms. You might have chronic discharge, itchiness, allergic type, conjunctivitis symptoms, but it could also be quite asymptomatic in some instances. We have patients that elect to observe lesions like this for many years even. All of these have been biopsied, and of course there are B-cell lymphomas, but keep in mind that lymphoid hyperplasia can also look quite similar to these lesions. So only a biopsy can really rule that out, that whether it's a benign versus a malignant lymphoid lesion. I would be interested to know if Carol has experience using OCT distinguishing the degree of malignant transformation of a lymphoid lesion. At any rate, and sometimes these are completely incidentally found. This patient had a basal cell carcinoma in my practice, but indeed on some careful examination, he also has a multiple lymphoma. So truly some of these are quite asymptomatic. So I mentioned biopsy techniques. In the case of conjunctival lesions, I think we often just rely on standard morphology and immunohistochemistry and H&Es because there just might not be enough tumor burden to be able to do flow cytometry or other more definitive lymphoma studies. But for the record, I think touch preps can be somewhat diagnostic, but flow cytometry is the gold standard. It kind of depends on how much tissue you have to work with. And I only include these various spectrums of orbital lymphomas just to remind you that the conjunctiva could be the tip of the iceberg. But fortunately for conjunctival lymphomas, the histology is usually very low grade, and it's probably 90% plus are multiple lymphomas. But keep in mind that other more aggressive histologies can also occur, but more commonly with orbital extension. And what do we do for workup once you make a diagnosis? There is really a need for ruling out systemic lymphoma. And I think PET-CTs can work. Bone marrow biopsies are sometimes done at cancer centers. I think most cancer centers still do bone marrow biopsies. Even for a conjunctival multiple lymphoma, I've had patients who have stage 4 conjunctival multiple lymphoma. That doesn't necessarily mean that they need aggressive treatment, but it could be that it gives you a clue that that's a patient that will get future relapse somewhere in extraocular sites. And so what about treatment? I think in the case of ocular surface lymphomas, probably 95% plus patients are treated with radiation. And the reason being, it's there, as I showed you, that it's low volume disease. Most often it's low grade disease. And most often it's limited to the ocular surface. So radiation has really served as the go-to treatment for ocular surface lymphomas. But perhaps, but it's good to note that there are many other forms of treatment for lymphoma that may be necessary if you have advanced stage or more high-grade lymphomas. So they are listed on the slide, but I want to kind of focus on radiation, which is probably the more practical solution for most cases of ocular surface lymphoma, and a little bit about dosing, because after all, we are ophthalmologists, and we very much like to offer the least invasive and the least toxic diagnostic treatment that is effective for curing the cancer. So the standard dose of radiation for low-grade lymphomas of the ocular adnexal has been about 24 to 30 grays in the last several decades. That takes about 2 to 3 weeks of administration because it's a daily fractionated dose that is delivered. And that has excellent local control, but it does have some ocular toxicity, mostly cataracts, mild keratitis, dry eye. So what about just the lower dose? And I think I shared this at the same meeting last year. We had fewer patients, but now I can share a more expanded experience with you. And we have been using just 4 grays of radiation, which is just 2 sessions, boom, boom, two daily doses of radiation, and we have been pleased with the results. Originally, this started with bulky orbital tumors, and we were very encouraged by resolution of even large tumors in the orbit with just 4 grays of radiation, but it also works for conjunctival disease, and it probably makes more sense with lower volume of disease on the conjunctiva. So what do we have in the way of data? The only publication we've done so far was of the first 23 orbits and eyes. These are some conjunctival, some orbital, and we had excellent response. 100% of the patients responded, but by RECIST criteria, about 56% had complete response, and a lot of them had very significant partial response. So there is a prospective trial underway at MD Anderson. Our accrual goal is 50 patients. We've so far accrued 41, and combined with our retrospective and off-protocol patients, we have treated 70 patients to date, and we are indeed very pleased with the results, and I hope to be able to publish the results of the prospective trial, and it may indeed lead to some change in the acceptable dose of radiation for low-grade lymphomas of the orbit, but also ocular surface. So I'm going to end with this case. It's a patient that has a fairly significant volume of conjunctival multiple lymphoma. You can see the extent of it. And she's been treated with 4 grays of radiation. This is from 2013, one of our earlier cases. And this is just to show you that there is prolonged treatment effect. That this follow-up picture is in 2017. So shorter duration, minimal toxicity, and can be repeated, of course, because of the small dose that is used and lower cost. So in summary, I think clinical recognition of salmon patch infiltrate is the most important first step for all ophthalmologists. The next step, in my mind, is a biopsy. Despite advances made with OCT, we do need the histology because we need to know the type of lymphoma because that very much dictates treatments. Staging is important as the next step. And then for stage 1E disease, probably very low dose radiation makes sense, particularly if long-term follow-up confirms our preliminary observations. Thank you.
Thank you.